Okay, today's class is on approach to patients with coma. Coming to the definition of coma, coma is first is consciousness. Consciousness is typically defined as presence of arousal in which one is able to interact with the environment, and awareness ability with the ability to know what is going on. So conscious is nothing but the presence of awareness, arousal and awareness. Arousal means one is able to interact with the environment. Awareness is ability to know what is going on in the environment. So next is coma. Coma is defined by the complete loss of both awareness as well as arousal. So apart from this coma, there are various disorders of consciousness. They act as a mimickers of coma. So what is delirium? It is a state of severe inattentiveness, altered mental content, and sometimes hyperactivity. So these are the different mimickers of coma. So coma is in condition patients with coma, there is an absence of arousal and awareness. There is no response to noxious stimuli other than a reflexic such as extensor or flexor posterior. So other mimicker of coma is differential diagnosis, persistent vegetative state, where arousal is preserved, where the person may not have a awareness. So it can be a transition from coma to prolonged coma. Eyes may be open, especially during the day, and there is no sustained reproducible response to stimuli. But these patients will have a stable and autonomic functions. So minimally conscious state. So here patient will have both arousal and awareness, but very minimal. So patient may make an eye-to-eye contact, or they can track the visual stimuli. Delirium, which I already told, it is an altered inattentiveness. So like in these patients, both arousal and awareness will be preserved, but it will be altered. So, but they both will not be absent or diminished. Another entity called as akinetic mutism, where patient appears to be arousable. He apparently, so but the awareness will not be there. So locked-in syndrome. In locked-in syndrome, both awareness and arousal will be preserved. There will be complete loss of complete paralysis, with the exception of patient will have only the vertical eye movements. So there is another entity called as psychogenic unresponsiveness. So here both arousal and appearance awareness will appear to be altered. Only on the examination we have to differentiate between the psychogenic unresponsiveness to other conditions. Coming to approach to patient with coma, whenever a person or anybody brings a person or a patient with a history suggest of unresponsiveness, so we have to approach these patients, whether this patient is having a coma or delirious or vegetative state, or it is just an metabolic encephalopathy, or it can be psychogenic. So first is history is very important. A detailed history is important in all cases of acute unresponsiveness. This is mainly to identify the process underlying etiology. So it should begin with a comprehensive history. So history regarding the coma itself, that is a history regarding the present state. So how was and where was the patient found? Whether patient was found in the home, or he found in the outside the home. So if it is at the home, if there is any witnesses, so how was there any abrupt loss of consciousness? Which abrupt loss of consciousness usually indicate a vascular disorder. Or the loss of consciousness is preceded by several days, or like a patient attenders may give a history that patient was few days back he was totally all right, and there is a slowly progressing loss of consciousness or altered sensorium. Altered sensorium. So there is a consciousness preceded by several days of worsening confusion. It might be we have to differentiate. Probably it might be a metabolic disorder or an evolving intracranial mass. So there were any evidence of empty pill or packets of empty pill or alcohol waters or around the patient that may suggest there is a possibility of intoxication. So there is a so family members, especially, they are very helpful in providing the information about the patient's medical history and is there any history of allergies. So what medical history we have to take? We have to take presence of any comorbidities. That's the patient is having any associated cardiac illness or a previous history of cerebrovascular accident, so which may increase the suspicion of ischemic event or an arrhythmia. So if there is any history of a cardiac illness or a patient who have a history of myocardial infarction, so it can be any other like complications of the same one or occurrence of arrhythmia. Or we have to also take a history what were the medications that patient was taking. Actually where they were medications were prescribed by a doctor or it's an over the counter medications. So whether patient was in any herbal supplements, so these may interacted with the other medication. Apart from this, we have to take a history. Is there any psychiatric history including the prior history of the similar illnesses or a prior history of suicidal attempts or a alcohol or a drug abuse. So, and apart from this, we have to take a history that regarding the other etiological, that is, it can be an infection. Though. So we have to ask a history of headache, history of fever in the days prior to the event. So it may imply an infectious etiology. So usually encephalitis or a malaria. So they also can these patients and also can present with the altered sensorium. Was there any confusion or difficulty in speech or language in the preceding days? So all this history has to be collected whenever the patient arrived to the casualty. So from the bystanders. So coming to the pathogenesis, what causes coma? So consciousness requires both arousal and the awareness. So coma, mainly the consciousness, the main structure is reticular activating system in the brainstem. So any lesion, whether it can be structural or a metabolic, so which disrupts the brainstem, and causing a damage to reticular activating system and its connection with the cerebral hemisphere. So any lesion, whether it can be any mass or it can be an infarction or a hemorrhage in the brainstem, or sometimes metabolic insults like hypoxic encephalopathy or a hypoglycemic encephalopathy. So structural and metabolic insults which disrupting the reticular activating system and its connection with the cerebral hemisphere to which it projects. So all these can lead to altered consciousness. So this is a table mainly indicative of a structural brain injury. So brain injury, it can be involving the hemisphere. Again, it can be unilateral, bilateral. So unilateral, it can be an hematoma or an infarction or intracranial hemorrhage or infectious etiology like abscess or a space occupying lesion. So bilateral means there can be penetrating traumatic brain injury or a multiple traumatic brain injuries, head injuries. ಅಷ್ಟೇ ಅಲ್ಲ. Okay, we'll continue with that. There is some internet problem. So I was saying, so coma can be due to anything causing a structural or a metabolic brain injury. So we'll see this table mainly showing a structural brain injury. So it can be unilateral insult to the brain or a bilateral. So predominantly unilateral, all of you know, it can be intracranial hematoma or a hemorrhage. So then the infarction involving the hemisphere, or it can be a hemorrhagic contusion, could be post-trauma or a trivial trauma to the head. And infectious etiology, it can be cerebral abscess, or it can be any space occupying lesions in the brain. So bilaterally, most commonly, it is penetrating traumatic brain injury or anoxic ischemic encephalopathy due to many causes. It can be due to patients with a respiratory failure or a cardiac arrest, seizures, hypoglycemia, any event causing anoxia to the brain. So it can lead to hypoxic ischemic encephalopathy and aneurysmal cerebral or subarachnoid hemorrhage, multiple infarct or a bilateral thalamic infarct, encephalitis. So these are the few causes causing a bilateral cerebral injuries. And involving the brain stem, mainly involving the brain stem is hemorrhage, that is a Fontaine hemorrhage or a basilar artery occlusion causing a major insult to the brain stem, or central pontine myelinolysis. Central pontine myelinolysis you must be knowing, so it could be over or a rapid correction of a hyponatremia or a hypernatremia. This is an irreversible damage to the brain, so to the hemisphere, so leading to central pontine myelinolysis or brainstem hemorrhage. So these are the few causes where involving the brainstem can lead to coma. So involving the cerebellum, it can be cerebellar infarct or hematoma or abscess. Coming to the metabolic insults to the brain, most common it is hypoglycemia. Hypoglycemia could be any cause. It can be insulin overdose or a patient who are taking an sulfonylureas. So they're the most common. These are the most common conditions where a person can come with a altered sensorium or unresponsiveness. Then hyperglycemia. Hyperglycemia is most commonly hyperglycemic non-ketotic hyperosmolar coma. It is also one of the most common acute complications in a patient with acute diabetes, in an uncontrolled diabetes mellitus, and other complications like a hyponatremia or a hypernatremia. Hyponatremia is a common metabolic event occurring in a hospitalized patient, hyponatremia. Hypernatremia, then the Addison's disease and hypothyroidism, all these and uremia. So uremia, even they also can present with the unresponsives. These are the metabolic causes for a coma. So these are other continued the structural brain injury. So hyperbilirubinemia, so causing an hepatic encephalopathy or a hypercapnia. So patients with a type 2 respiratory failure with a carbon dioxide narcosis, they also can come with the altered sensorium or a unresponsiveness. So other causes where we get a diffuse damage to the brain or a diffuse brain dysfunction. One is generalized tonic-clonic seizures or a patient who was taken a poisoning, that is a OP compound poisoning, or a illicit drug use, that is a drug abuse, or a patient who is a psychogenic psychiatric medications who has come with a drug overdose. It can be benzodiazepines or a barbiturates. Hypothermia is the most common in patients with drowning. Then the neural malignant syndrome or acute catatonia. So these are the diffuse brain dysfunction conditions where patient will get a diffuse brain dysfunction. Then the other common, these are all psychogenic unresponsiveness, also commonest, one of the commonest presentation to emergency department, that is hysterical or a malingering. So it is our responsibility to differentiate between whether it is a psychogenic unresponsiveness or an unresponsiveness due to structural or a metabolic brain damage. So coming to the physical examination, so very important part. Whenever a patient arrive to the casualty with unresponsiveness, so apart from the history, so we have to approach to the patient based on the general. We have to start our examination from the general examination. So we have to assess the vital signs. So these vital signs may provide clue to the etiology of the patient's unresponsiveness, hyperthermia or a hypothermia. Hyperthermia can be most commonly present in a spontaneous hemorrhage, or hyperthermia can be present in an infection. So infection, it can indicate a usually cerebral malaria or an encephalitis. And sometimes in a hyperthermia can be present in drug overdoses or a tricyclic antidepressants. So hypothermia is most commonly present in patients with mixed edema, drowning, or an alcohol intoxication. So we can get a patient can get hypothermia. Then hypertension. So hypertension, if a person presenting with unresponsiveness with accelerated hypertension. So if the BP is more than 220 by 140, we call it as a accelerated hypertension. So most commonly it can be due to hemorrhage, that is intracranial hemorrhage, or it can be cerebral infarction. So hypotension, even hypotension can also cause a unresponsiveness. How hypotension? So it causes a decreased perfusion to the brain. So hypotension could be because of sepsis, causing a sepsis shock, or a volume loss, hypovolemia can be due to if a patient has a many episodes of diarrhea. So they also can come with ulcer sensorium or a unresponsiveness. So then we have to like a urinary or a fecal incontinence. So it can be presence of a urinary incontinence or a stinking the cloths. It can be unwitnessed seizures. So it can be patient attenders may not be noticed that patient is having a seizures. So we have to, so presence of incontinence or evidence of incontinence, it's unwitnessed seizures. Then the scalp should be evident palpated for the signs of trauma, and the ears and nose should be examined for the blood stain or a presence of a cerebrospinal fluid. Then the respiratory pattern after the vital signs. So we have to check the respiratory pattern. There are the different respiratory pattern which can give clues to the organic brain injury. So these are the different chain strokes breathing, cluster breathing, ataxic, apneustic, or a central apneustic hyperventilation. Chain stroke breathing. What is chain stroke breathing? Increase in rate and depth of the respiration. So there is an increase in rate and apnea followed by hypopnea. So patient will have a crescendo decrescendo breathing pattern. So it is usually bilateral hemispheric lesion. So that is chain stroke breathing. Then the cluster breathing. So irregular clusters of breaths followed by apneic periods. So usually it is a bilateral diffuse cerebral hemispheric lesion, or it can be fontaine or a brainstem lesion. Then the another entity called as ataxic. Ataxic is usually seen in a patient with encephalitis. So patient will have an irregular respiratory rate, irregular in rhythm, and irregular in amplitude. So and it can be interrupted by the apnea. So that is ataxia. Ataxia means there is imbalance. So imbalance, that is imbalance in the respiratory rate, rhythm, and amplitude. That is called ataxic breathing. So then if we get a Kusumal's breathing is increase in rate and depth of the respiration. Usually we get in patients with a diabetic ketoacidosis. So chain stroke breathing we get in bilateral hemispheric lesion. Kusumal's breathing we get in diabetic ketoacidosis. Cluster breathing means irregular clusters of breath followed by apneic periods of variable duration, usually in diffuse hemispheric or a fontaine lesion. And ataxic breathing, it is not usually not localizing. It can be lower brainstem, or it can be in a encephalitis patient. Apneustic breathing, that is a prolonged inspiratory. There is an inspiration with a pause more than 2 to 3 seconds. Then patient will have a expiration. So patient will take a deep inspiration and he'll have a pause, then followed by expiration. So usually apneustic breathing in the pons. Cluster breathing we'll get in upper pons. Apneustic breathing we get in lower pons. So sustained hyperventilation. So it is usually patient we come across in patients with metabolic acidosis or patient with a left ventricular failure, hypertrophic encephalopathy. So these are the few causes where patient will have a increased rate and depth of respiration. So these are the clues for this table mainly shows us that the clues physical findings, that is hypertension. So hypertension can be present in many conditions. Hypotension can be present in many conditions. So only thing is like we have to see what is relevant to the patient's history. So we cannot assume pheochromocytoma in all patients. So we cannot assume eclampsia unless there is a patient has a preceding history of accelerated in a pregnant patient with a preceding history of accelerated hypertension. So it is what is clinically relevant with the patient's history. Hyperthermia, so if patient gives history of fever, so we can think of infectious conditions in that patient, or neural malignant syndrome if patient is having an antipsychotic medications. So we have to suspect a hyperthermia and we have to approach these patients according to that only. Hypothermia. So hypothermia is usually patients with hypothyroidism, hypoglycemia, or if patient has an environmental exposure, or sometimes secondary to drug ingestion like barbiturates or sedatives or hypnotics. So whenever a patient we come across with hypothermia, we have to suspect all these conditions and we have to ask a history relevant whether patient has any history suggestive of drug overdosage. How to suspect if patient barbiturate consumption. So if either a patient will be taking barbiturates or somebody at home will be taking barbiturates like a phenobarbital for their medical conditions. So presence of tachycardia at arrival. So tachycardia means it can be because of an infectious etiology, or it can be secondary to drug abuse also. Then bradycardia. So bradycardia is usually give a clue to myxedema or bradycardia due to drug ingestion. So that is a drug consumptions of beta blockers or a calcium channel blockers. So these are the like clinically what is relevant to the patients. Based on these findings, we have to go back to the attenders and take a history what is possible, whether they clue to the diagnosis. So again, if there is any bedside, if there is any presence of odor, so it can be uremic odor or a fruity sweat that is in ketoacidosis or a fishy odor in patients suspicious of acute hepatic failure or a suspected hepatic encephalopathy, or in a onion smell that is in patients with paraldehyde or a garlic odor in patients with insecticides or a organophosphorus consumption. Then examination of the skin. So why do we look into the skin clue? So this is mainly, this table mainly helps in unresponsiveness of unknown etiology. Somebody has brought some patient with unresponsiveness, even they doesn't know what has happened in the background of that patient. So these are the clues and the physical examination. So diaphoresis, if patient has got a sweating, so it can be thyroid storm or a hyperthyroidism or an hypoglycemia. So hypoglycemia, usually patients, diabetic patients who skip the meals and taken anti-diabetic medications. So in hypoglycemia patients, the presence of diaphoresis itself is an increased sympathetic activity. So acute sympathetic hyperactivity can lead to diaphoresis. Presence of a dry skin. So again, presence of a dry core skin is clue to hypothyroidism. Then the presence of an acne over the face, it can be secondary to phenytoin, that is anti-epileptic consumption. And sometimes there may be bulla over the skin. So drug exposures like commonly barbiturates and the presence of butterfly rash, that is systemic lupus erythematosus, and the dark pigmentation over the lips and the sun exposed areas is suggestive of an Addison's disease. So why do we have to see? Is there any skin and the Addison's and the coma is there? So whether the patient who have a dark pigmentation, if you think Addison's disease, so along with it, not only presence of a dark pigmentation, we cannot arrive at Addison's disease. So what else we have to think other supportive evidence of Addison's disease. So they are the one patient will have a hypotension, hypoglycemia. So patient will have a previously he'll be ill or a fatigability or patient who is on steroids. So sudden withdrawal from the steroids, patient can get into coma. So that is secondary additions patient can develop. So these are the history you have to, once you get a finding of a dark pigmentation, if you suspect additions, then you have to ask the relevant history to the attenders whether patient was on any steroids or patient was sick long before presenting to this casualty. Okay. So then coming to the cold clammy extremities or a puffy face usually suggestive of a myxedema. Then the presence of a purpura. So it can be due to vasculitis. So once here I told it is a butterfly rash is a systemic lupus erythematosus. So it can be presence of a purpura, it is a vasculitis. So we have to look, once we look for a butterfly rash, we have to look for any evidence of vasculitis or any other generalized rash, maculopapular rash, clue to the infectious etiology, that is in the meningococcal meningitis we get a petechiae and rashes, and even in the viral encephalitis like a dengue encephalitis or a rickettsia. So usually rickettsial infections are the missed ones. So rickettsia. So these are the certain infectious etiology where even patient can come with a coma. Unresponsiveness. Okay, so coming to the neurological, once we complete our general examination and physical vital signs and other physical examination, we have to go to the neurological examination, and definitely we have to examine the other, apart from neurology, we have to examine the systemic other systems like a cardiovascular system examination and respiratory system examination. Why do we have to do the other systems also? Because a patient who has come with unresponsiveness, it can be status epilepticus. So patient can have an aspiration pneumonia and respiratory distress also. For that sake, we have to examine the other system. So we have to give importance for the examination of the other symptoms also. So coming to the neurological examination, whenever patient arrive to the unresponsiveness, so we have to assess the patient on a certain, we have to give a grade to the coma scale. So we call it as a coma scale. That is mainly to localize the lesion and narrow down the differential diagnosis and the depth of the coma. So mainly depth of the coma is assessed by using a coma scale. So we have two types of coma scale, that is a Glasgow coma scale. So it is most commonly used coma scale in ICU or a bedside or in a emergency department. So here the coma scale consists of three components, that is eye movements, best motor response and the best verbal response. But there are certain drawbacks of this GCS, that is a Glasgow coma scale, which will not assess the brainstem reflex. So which will not detect the subtle change in the neurological status of the new patient. So this table is mainly Glasgow coma scale. So Glasgow coma scale, usually we have a, so best eye response. So the topmost scoring is the normal one, that is spontaneous eye opening, we have a scoring of 4. Eye opening to verbal command, we have a score of 3. Then that to the pain, it is 2, and no response is 1. Then the verbal response, whether patient is oriented or a confused or then the inappropriate words, then the incomprehensible words or sounds, and no noise response. Then the motor response gives the highest, that is a 6. It starts with a 6. Obeys the commands, localizes the pain, withdraws for the pain, or flexion response to the pain, extension response to the pain, or a no response. So this is EMV. So this is a Glasgow coma scale. Maximum number is 15. So to address the shortcomings of this GCS, the Glasgow coma scale, so there is another scaling score that is called full outline unresponsiveness score, that is called as 4-score system is developed. So this has got a 4 components. One is eye, motor response, brainstem, and it includes the respiratory rate also. They are normally graded from the scale 0 to 4, and it has got a maximum total score of 16. So in this 4 score, there is a greater emphasis is put on brainstem reflex as well as respiratory pattern. So why this 4 score is laid on means it has got a predictive value in terms of a progression towards the severe injury. It has got a prognostic value also. So this chart is mainly 4 score. So that is eye movements. Then the motor response, this is the brainstem reflex. Brainstem reflex is again the pupil and the corneal reflex, and whether pupil is wide and fixed or the reflexes are absent, like that. Then the fourth is respiratory pattern. So here E4, E3, E2, E1, E0. So again eyelids, eye response is eyelids are open or tracking or blinking to the commands. That is a maximum, that is a normal one. So eyes are open, they are following the commands, they are tracking our commands. So three is eyelids are open but they are not tracking. So eyelids are closed but when we give a voice they open. But in grade one, in last one is the closed, they open to the painful stimulus. Zero is they are closed with open to the painful. They, even with the pain, it will not, they will not respond. So motor response is again when you ask the patient how are you, that is thumbs up. So that is like it is a peaceful sign. It's a good sign. So then if you give a painful stimulus, localizing the pain is a grade 3, and the score of 2 is flexion response to the pain. Score of 1 is external response. If no response means it's a 0. Then the changes in this mainly brainstem reflexes and the respiratory. So brainstem reflexes about the pupils. So pupillary and a corneal reflexes are present means it's a score of 4, and one pupil is wide and that's an asymmetry of the pupil. So it is 3, and the 2 is both the reflexes are absent, and 0 is absent, and cough reflex also absent. So all the brainstem reflexes are absent means it's a 0. Coming to the respiratory patterns, so patient score of 4 is normal. It's a not intubated and regular breathing pattern. But respiratory score of 3 is not intubated, but it's a chain stroke breathing. So like that, at the 0 breathes at a ventilator rate, means grade 0 or a score of 0 patient is on ventilator rate or a patient is having an apnea. So this is very important score for the assessment of a patient with unresponsiveness. So then apart from this, one is basic, we have to give a depth of the coma. So we have to use either a Glasgow coma scale or a 4 score. So then next is we have to go for a cranial nerve examination. We have to, so in unresponsiveness, so we have to start with 1 to 12. So but there are only feasible, we cannot do the testing of the olfactory nerve. So second, third, so we have to go for a pupillary size and the position of the pupil, and whether it is a pinpoint pupil or a dilated pupil. So if the presence of a pinpoint pupil or a minimally reactive or unreactive to the light usually suggests of a pontine hemorrhage or a lesion in the pontine pons which interrupts the descending sympathetic flow. Then the small pupils can be many other toxications, toxic compound consumption. It can be an opioid or a OP compound consumption. So dilated pupil more than 8 millimeters. So it can be third cranial nerve damage secondary to either an injury or either even a lesion of a peripheral nerve injury. So like a mid-size fixed pupil are seen in usually midbrain lesions, and it can be secondary to herniation. So we have to look for a pupillary response. So whether sympathetic damage, so meiosis is there, we have to think of an Horner syndrome. So presence. Next is eyeball movements. So you all know in unresponsive we cannot do any voluntary movements. So we have to do we have to examine the patients for eye movements. So first we have to check for the eye movement whether they are the deviated. So eyes are deviated. So if eyes are conjugately deviated away from the this is more important in a patient who have a stroke or a hemiparesis or a convulsions. So if suppose a patient has an hemiparesis, so if the eyes are deviated away from the hemiparetic, means it is looking towards the destructive lesion. Means patient eyeballs are looking towards the opposite normal limb, or that is suggestive of a pathological brain damage. So that is usually suggestive of a destructive cerebral lesion. So eyes are looking towards the side which is affected. If the eyes are turned towards the paretic limb, means it is a pontine lesion or it can be adversive scissors. So disconjugate at rest usually indicate. Disconjugate means so both are looking in a different different directions. That is called disconjugate. So above which I told is conjugately deviated away from the hemiparetic limb or looking towards the paretic limb. So they give a clue whether it is a cerebral or a frontal lobe lesion or a pontine lesion. So if the eyes are disconjugate at rest or a neutral position, so it indicates there is a paresis of the extraocular muscles, that is, or it can be intranuclear ophthalmoplegia, or if patient has a pre-existing trophy or a phoria. So then we have to look for, is there any spontaneous movements, that is a ping pong or ocular dipping indicates of a bihemispheric dysfunction, ocular bobbing. Okay. So if there is a metabolic abnormality, they can also have a classic roving eye movements. So eye movements can be unilateral or a bilateral. So usually we have to examine for the doll's eye phenomena or a caloric test. So that is doll's eye phenomena is oculocephalic test. Passive head turning causes the eyes to deviate conjugately in the opposite direction. That is called doll's eye phenomena. Caloric test is irrigation of each ear with a 30 to 100 ml of ice cold water when head is elevated at 30°. It produces the conjugate deviation of the eyes towards the stimulated ears. So these eye movements are usually, that is an intact in early metabolic encephalopathy, but they can be lost in a long-standing anoxic encephalopathy. So usually disconjugate eyes means it is a brainstem lesion or it can be cranial region. So these are the eye movements abnormalities in coma. So it's a periodic alternating gaze or a ping pong or a convergent nystagmus or a bobbing, dipping. So these are the different type of eye movements in a patient with unresponsiveness. So apart from these eye movements and pupillary reflex, we have to examine the patient's fundus if feasible. So we have to look for a vitreous hemorrhage. So usually indicative of a hypertension. And we have to also look for a papilla edema in these patients. So downward eye deviation. So it can be a lesion in the rostral midbrain or a thalamus. So it indicates a brainstem damage. Coming to once the cranial nerve, we have to briefly look for the motor response. So how to look for the motor response in an unresponsiveness patient? So we have to apply a, we have to give a verbal response. Definitely patient is unresponsive. So next we have to examine the patient with the bedside skills. One is motor response by giving noxious stimuli to the supraorbital nerve with the nail bed or in a temporomandibular joint, assessing the patient's reaction to the stimulus. So one is stimulus is localizing response or a reflexive response. Localizing response means patient reaches towards the stimulus. He localizes the stimulus. That is called localizing response. And the apart other than this is reflexive response. That is decorticate or a decerebrate posturing or no response at all. So these are the three types of response: localizing or a reflexive or a no response. So that give clue to the motor examination. So decorticate means so it's a slow flexion of the elbow at elbow joint or a wrist or a fingers. That is decorticate. Decerebrate means adduction, internal rotation of the shoulder with arm extension and wrist protection. That is decerebrate posturing. So even in unresponsive patients, we can get a subtle spontaneous movements that can be generalized myoclonus, which is usually suggestive of an poor outcome. So usually this myoclonus is present post cardiac arrest and due to anoxic ischemic injury. So coming to once we have done a brief examination of the patient, we have to proceed for the investigation for unresponsiveness. So baseline is we have to get a hemogram. We have to, whenever patient arrive to the casualty with unresponsiveness, we have to get a blood glucose levels. So we have to get a glucometer random blood sugar estimation. If it is low at the bedside, you have to correct it immediately. So if the blood sugar is normal, then we have to proceed for the further investigations for his unresponsive. So So apart from the blood routine and all, the other special investigation has to be done on arrival to the casualties, neuroimaging. So we have to consider doing a neuroimaging if we are not finding any reversible causes on arrival to the casualty. So we have to get a baseline CT brain plane. So it's the fastest and the most readily available imaging modality in all, more or less in all the tertiary centers. So one is we have to look for a cerebral edema. Second is we have to look for an intracranial hemorrhage and infarction. Apart from this, any other structural abnormalities like hydrocephalus, or is there any intracranial space occupying lesion? So next is EEG. EEG is considered when we suspect a status epilepticus. It's unresponsiveness, ongoing subtle movements. So we have to think of a EEG. So to diagnose a unresponsiveness, and LPCSF analysis if there is a patient is having a fever at presentation or a temperature is high at the exam and patient attenders give clues that patient had a history of fever previous days. So we have to do a lumbar puncture and CSF analysis to diagnose the neuro infection. Apart from this, routinely we have to get a hematocrit, hemogram, platelet, peripheral, and a blood smear, and also the malarial parasite. So platelet, it could be dengue encephalitis also, and cerebral malaria also. So for all this, we have to get a routine blood examination has to be done in all patients with unresponsiveness. And other than that is electrolyte panel, which includes the sodium, potassium, calcium, magnesium, phosphorus, and also blood sugar levels. And next is creatinine and blood urea. Liver function test mainly to know is there any, if patient is alcoholic or on examination, if we find there is a jaundice or icteric on examination, we have to definitely get the liver function test. Along with that, we have to estimate a serum ammonia levels. Then routinely, if there are no clues, again we have to go with the extended investigations like serum and urinary osmolality, arterial blood gas analysis. So this is the flow chart, mainly emergent care of coma patients. So once the patient has come with unresponsiveness, so if patient requires a intubation, definitely you have to intubate and ventilate. Or if doesn't require, if blood pressure is high, we have to stabilize the blood pressure first. Then we have to look for the examination, whether it is an hemispheric lesion or a structural lesion or a metabolic cause or it is a brainstem. So all of you know if it is an hemisphere lesion. So it can be an infarct means patient will have a hemiparesis or a monoplegia or a hemiplegia. So if it is a brainstem means patient can have a con with unresponsiveness, pupillary, or he can have a examination clues to the cranial nerve involvement. So more or less in all patients with unresponsiveness, we have to get a CT or an MRI. So if CT is normal, so we have to think of either a toxin or a status epilepticus or an underlying infection. We have to work up for an endocrine or a metabolic or a anoxic ischemic insult. So toxin means we have to get a drug screening. So based on the history, we have to take it from the attender, the barbiturates levels or a benzodiazepine. If it is a status epilepticus, we have to consider giving a anti-epileptic loading dose. Infection means you have to work up for an infection like cerebral malaria, dengue fever, and you have to go ahead accordingly. Endocrine or metabolic means we have to get an hypothyroidism or an Addison's disease workup, and we have to treat based on the reports. So these are the patients we have to investigate in a patient who have got a CT scan or MRI brain normal. We have to think of all these 5 conditions. Suppose if it is abnormal, so whether it's a cortical or a brainstem, okay. So if it's a cortical means you have to go with the infarct or a hemorrhage. If it's a brainstem, again we have to, if patient will have a respiratory abnormality, we have to intubate and proceed. So whether patient has a brain or cerebral edema, we have to give an anti-edema measures. If patient, if the MRI or a CT brain is suggestive of a subarachnoid hemorrhage, so we have to definitely proceed for the surgery and clipping if patient has an aneurysm. Okay, so this is the clue, baseline clue and the patient at, so then coming to again the coma patients intubate if it is necessary or a pressure stabilization. So whether it's a brain or a cerebral hemisphere involvement and shift of the brainstem or intrinsic brainstem lesion. So based on this, we have to proceed the treatment. So this completes the approach to coma.